I've received a feedback from a number of colleagues and medical students that the previous videos on ABGs was a bit complicated and perhaps meant for the physician. So I have decided to make another video, but this one is for the surgeons and in fact for the non-physicians. The questions which I'm sure every surgeon or anesthetist would like to would like answered from an ABG report is what kind of pH there is, whether there is acidosis or alkalosis, and especially if there is acidosis, what kind of acidosis there is. And the third question is whether or not this patient requires ventilation and what can be the further treatment for that. So I've written down these three questions, and this video is specifically for the non-physicians and especially for the surgeons. What I have here is a few ABG reports, which have also been mentioned in the previous videos. And just to summarize, a particular ABG report will have these variables: pH, PCO2, PO2, bicarb, base excess, and oxygen saturation. We can ignore the base excess, but what we need is the pH, the PCO2, the PO2, and the bicarb. So these are the four variables which are important when you look at an ABG report. The pH, the normal pH, remember, it is between 7.35 to 7.45. So that's the normal one. If the patient has a pH which is greater than 7.45, as you can see in this particular report, this becomes alkalosis. That means a pH of greater than 7.45. So this is an alkalotic pH. This is an alkalotic pH. Here, this is an acidotic pH. So you can see that these are acidotic pH. So any pH which is less than 7.35, this is going to be labeled as acidosis. So these three readings are those of acidosis, and these two are those of alkalosis, and this one is actually trending towards alkalosis as well. Once you've established the pH, the next thing is to look at the PCO2. The PCO2 tells us about the state of the lungs, about the ventilatory capacity. Say, for instance, if somebody comes with cerebral depression, somebody has taken Valium overdose, somebody has taken morphine, or somebody has been given great amounts of morphine, the PCO2 is going to rise because there'll be less ventilation. Less the ventilation, greater the blood will show PCO2. Once you've established the PCO2, as you can see here, a PCO2 value of greater than 46 is going to be labeled as hypercapnia. So this is hypercapnia. The body is retaining carbon dioxide. It is not being blowing out. So there is a problem with ventilation in this particular ABG. So the PCO2 is high, that is 60, so that means it's not going out. So therefore there is a problem with ventilation. And this can be confirmed by looking at the O2 value as well. So if the O2 value is low, as you can see here, then this confirms that this patient has got respiratory problem, has got a ventilatory problem, whether there is a problem within the lungs, for instance, that they may have had trauma to the chest, they may have had pneumothorax, bilateral problems, severe pneumonias, or they could have had cerebral depression because of drug overdose. For instance, they've been given they'll be given extra amounts of anesthetics. The pH is going to fall. Once you've established that, then you can go down to look at the bicarb. If the bicarb is on the lower side, then this means that they also have an element of metabolic acidosis as well. So a low bicarb and a low pH means that there is an element of metabolic acidosis, or that this is a non-compensated respiratory acidosis. This has not yet been compensated. All the bicarb has been consumed, and so therefore this still is a non-compensated respiratory acidosis. So I hope that makes it clear about the difference between acidosis and alkalosis. Then when you come to the type of acidosis, you want to establish whether this is a metabolic one. When you say metabolic, that means something is wrong with the blood. The commonest one is lactic acidosis. Lactic acidosis is seen with low blood pressure or in a state of shock. So anybody who's in a state of shock can develop lactic acidosis, and with lactic acidosis you will develop a low pH. But when you develop a low pH, the body compensates that by blowing out carbon dioxide. So if you got a low pH and less than 7.35 and a low PCO2, that means this is likely to be metabolic acidosis, and so therefore you would expect the bicarb to be low as well. As you can see in this case, you can see the bicarb to be low as well. So that's the picture which you see. But if the PCO2 is high, this is not metabolic acidosis. This is a respiratory kind of an acidosis with a metabolic component. This still has not been compensated. The other causes of lactic acid or the other causes of metabolic acidosis are ketoacidosis, the commonest one. You don't have to remember all of them. Ketoacidosis, that means diabetic ketoacidosis. And the third one is uremic acidosis. Uremic acidosis does not occur in stable chronic renal failure. For uremic acidosis to occur, you must have an acute event. For instance, acute sepsis, acute obstruction, acute something acute, for instance, trauma, medicines, or anything of the kind. So uremic acidosis will not occur just in every CKD patient. Uremic acidosis has to have an acute event. So often you will see AKI on top of CKD, and this leads to uremic acidosis. And when I said diabetic ketoacidosis, so this is something which you can fairly see. This is not a picture of metabolic acidosis. This is not a picture of metabolic acidosis. The reason being the PCO2 is high. This one, on the other hand, with 7.169, this is acidosis, but the PCO2 isn't very high. The PCO2 is within range. Now let's look at the bicarb, and the bicarb is 13.9. So this patient has got an acidosis, but it's more likely to be a metabolic picture rather than a respiratory picture, because still the PCO2 is within range. If the PCO2 falls, this is confirmed metabolic acidosis with respiratory compensation. Now let's look at this particular one. The pH is 7.5, so this is on the alkaline side. The PCO2 is 34, so this is actually on the bottom side of the normal. And let's look at the PO2, and this is also within range. And bicarb is 31. So with a bicarb of 31, this is alkalotic. So this is metabolic alkalosis without significant respiratory compensation. Had there been respiratory compensation, you would have expected the PCO2 to be around 46, because the body will retain PCO2 in order to bring this value down and bring this value to within range. So this is still not compensated. This is an uncompensated ABG report. Let's look at this one. So this again is metabolic alkalosis. The PCO2 in this one, as you can see, is now 22, and the bicarb is 23. So the bicarb is within range, but there is metabolic alkalosis. And you can say that this is metabolic alkalosis with respiratory compensation. The PCO2 has fallen down. I'm sorry. There isn't any respiratory compensation, because had there been respiratory compensation, it would have been on the other side. And the bicarb is within range. So this is a metabolic alkalosis, but we're still not sure about the respiratory component or the bicarb component. But this is something which will develop gradually as we go along. Once you've established the kind of alkalosis or acidosis, the next most important question is whether this person needs ventilation or not. Hardly ever would you have to make a decision about artificial ventilation in an alkalotic patient. It's unlikely, it's uncommon, because it's not really that much of a problem. But on the other hand, when it comes to acidosis, because of the PCO2 factor, you often may have to decide about ventilation. In this particular case, with this ABG, this patient requires ventilation, because The oxygen saturation is just 63. The PO2 is only 48, and there is severe metabolic acidosis. So this person requires acidosis, requires artificial ventilation. So does this person. The oxygen sats are low, just 83. The PO2 is 74 on the low side, and the PCO2 is gradually getting worse. So this patient also requires ventilation. Now, this particular patient with a pH of 7.169 and a PCO2 just 40 and a bicarb of 13.9 with oxygen sats of 86 does not require ventilation. This patient can still be managed without ventilation, and so therefore these two require ventilation because the oxygen sats are falling, PO2 is falling, but with this particular ABG, the patient does not require ventilation. So I hope that this makes it simpler for our non-physician friends to make a decision when they see an ABG report. Thank you.